I think maintenance therapy, we've probably made it more complicated than it needs to be. I think it always seemed to make sense that if somebody's doing well, both in terms of the cancers being controlled with what you're doing, and they're not suffering from a side effect of that therapy or that approach, even if it's as simple as fatigue, then trying to continue that approach, at least intuitively, made sense. Well, we now have data to support that approach. That we know that if you continue some drugs like pemetrexed, or in some cases erlotinib, where that gets added to someone's care, that can allow patients to continue to benefit and actually improve their overall survival. For me personally, I do not tend to switch patients. So where I start them on treatment A, they do well for a while, and then I switch them to treatment B as their so-called maintenance therapy. I don't do that. I guess one could get into a debate about why one does and doesn't do that. I simply don't do that because I feel like that's just bringing in what I was going to do anyway earlier, and I'd rather wait and let patients enjoy time off therapy before we try that again. And again, selfishly, often it's because I also want to consider opportunities for a trial. Some trials won't allow patients to have had that switch or second therapy. But in the other case where you're on treatment A, you're doing well, continuing treatment A as a maintenance approach I think is very reasonable. Notwithstanding these tremendous costs, I don't pretend that continuing a drug like pemetrexed is a cheap proposition. I know it's very expensive. Not only the dollars paying for that, but patients coming in for co-pays and driving in and parking and all that stuff. Just, it's a tremendous burden for patients. But I do think the data support that approach over stopping and just waiting for a patient to progress and starting therapy. So I have several patients, many patients, where I've done this with pemetrexed and I've had them stay on it for a long time. I think I'm helping them ultimately, but you always do feel bad or guilty about making somebody continue on that pathway. I always make it clear at every visit, though, that once we're beyond the initial induction piece and we're into maintenance therapy, if they want to stop or they want to take a break, we should do that, or we can do that, and that happens. And so patients, I think, welcome an opportunity to take a month off or 3 months off or 6 months off. Of course, we've all, I think, shared the experience of where we've done that and we've brought patients back and they have progression in their cancer. And I think there's some regret sometimes on the part of patients and doctors when we've made that decision. But I think it's usually the right choice when a patient wants to take a break to make sure they can have that break.